All right, hello guys. Hey, we're going to go over some EMS-CEU. This is a review of the protocol for albuterol. So we're going to talk about the formulary for albuterol and then talk about its delivery systems real quick and just refresh on it. So let's start. If you want to follow along in the video, I'm going to read through the protocol as we go. If you want to follow on your phone, just read the protocol on your own. Open up your protocol app and you're going to go to number 16 formulary and you're looking for 16C, which is albuterol. If you are given this class, if you're the instructor for this class at your station, you can use your Chromecast and put this on the TV. You can Chromecast this video because it's on YouTube, or you can just Chromecast your phone and listen to the video, whatever you'd like to do. But all right, guys, let's get started. So albuterol, 16C. Albuterol is a basic medication. It can be administered by basically anybody. It's prescribed to regular patients all the time, and given in breathing treatments every day. It's one of the safest drugs we have. Has very little contraindications to it. One of the very few times that we won't use it is if we suspect that the patient is having a breathing problem due to CHF, or they're allergic to albuterol. That's about the only contraindication to it. So it's extremely safe, and it should be used probably twice as much as we use it. And we'll talk about why, okay, when we get into some of the protocols we use in. Just starting with the formulary here. It is a bronchodilator, okay, so that albuterol just dilates your bronchioles and opens your airways up so that you can breathe better, right? So we use it for in cases of bronchospasm, which we just learned about on our entitled CO2 review protocol, or CEU video this month as well. So you know what I'm talking about. So we find bronchospasm. We have two ways we do that. Entitled CO2 is one. The other is lung sounds. We treat wheezing. Wheezing's our indication for bronchospasm, and we treat that with albuterol. So it's a bronchodilator. It's relatively selective ablative 2 adrenergic stimulant. Albuterol causes relaxation of the few muscles in the bronchial tree, thus decreasing airway resistance, facilitating mucus drainage, and increasing vital capacity. So that's a lot of words. That's a mouthful. Basically, what we know, it relaxes the muscles in your bronchus, in your bronchial tree, and makes it easier for you to get air in and out of your lungs. It also helps to remove, helps mucus drainage if you have mucus in your airway. Therapeutic doses of albuterol by inhibiting histamine release from mast cells also reduces the mucus secretion, capillary leaking, and mucosal edema caused by allergic response in the lungs. So that is one of the other reasons why we use albuterol, in particular during allergic reaction. Our indications for albuterol, we have dyspnea, uncertain etiology, and that's going to be the most commonly used protocol that you have that comes to respiratory is dyspnea, uncertain etiology. And we'll get into that in a minute and talk about why we don't use albuterol enough. And then we'll also talk about COVID and why we should never use it with COVID. So dyspnea, uncertain etiology, dyspnea, asthma. So our problem during asthma is that we have bronchial spasm, right? And this is a bronchial dilator, so that's what we use it for. Dyspnea, COPD, same thing. The difference between asthma and COPD is asthma is acute and COPD is chronic. So you're going to have chronic narrowing of the airway with COPD, and then you have an exacerbation. I can't even talk right now, sorry. You have a worsening of COPD, and that causes more bronchospasm, an acute case of worsening bronchospasm, and then we get a call. So we use albuterol to treat that. Next is acute allergic reactions, right? So we use, on any allergic reaction where a person says that they feel like they're having trouble breathing, they should get albuterol. Okay, it's very, very safe. As we see, there's almost no contraindications for it, so there's no reason to ever withhold it. You see in allergic reactions, us rush to Benadryl a lot. It's kind of an old school way to do it. But we know that epi and albuterol are more important than Benadryl. Epi and albuterol both treat problems that are happening sooner. So it is more important that we give those two than Benadryl with allergic reaction. Bee stings, wasp stings, same thing. So the reaction from a bee sting and wasp sting cause bronchial spasm, narrow the airway, shortens the breath. We use albuterol to treat that. And smoke inhalation. Okay, same thing. Smoke irritates smooth muscles of the bronchus, therefore causing spasm, narrow the airway, harder to breathe. Albuterol treats that. Also with smoke into your lungs, we have an increased secretion of mucus with your airway trying to protect itself. And as you see there, this reduces that and helps facilitate the drainage of that. So very good for smoke inhalation as well, which is important for us. So contraindications, let's get to that. As I said before, a known hypersensitivity to albuterol, so allergic to albuterol, and should not be used if the sole etiology of dyspnea is strongly suspected to be CHF, as albuterol-induced tachycardia may worsen the compromised cardiac output in CHF. The other thing you'll hear talked about a lot is flash pulmonary edema caused by albuterol and CHF. So we hear this a lot, and definitely something that you should be suspicious of. It does happen, but you don't normally get somebody that just has CHF. If you do, definitely albuterol is going to be contraindicated, but usually we have a patient that has CHF and COPD, so then we're using our end tidal to determine which one we think is the sole problem. We're using our end tidal CO2 and our lung sounds, and we're listening. Are we hearing gurgling and fluid in the lungs, or are we hearing wheezing and seeing bronchial spasm on our end tidal CO2? So you can definitely use albuterol just based on a protocol. We're going to say this is uncertain etiology, and we're just going to give albuterol. The protocol says everybody that says they're short of breath, and you don't have a certain etiology, so you're using dyspnea, uncertain etiology as your protocol, should get albuterol. So we break the protocol all the time, but you can use it that way. You can just give albuterol to everybody that says they're short of breath, and eventually you're going to run into somebody that's CHF, and you're going to cause a problem. So what we should really be doing is using our lung sounds with our stethoscope, and then using our end tidal CO2 to find bronchial spasm in the waveform and in the lung sounds through wheezing, and then we treat that with albuterol. And if we're not seeing bronchial spasm on the end tidal, and we're hearing fluid in the lungs or gurgling sounds in the lungs, that's going to be fluid, and most likely it's going to be strongly suspected to be CHF, and therefore we're going to withhold the albuterol. So next, our onset within 5 to 15 minutes, peak effect 1 to 1.5 hours, duration effect 3 to 6 hours, half-life less than 3 hours. When inhaled, albuterol is distributed to muscle cells along the bronchial tree. Very little is systemically absorbed and distributed. All right, so not a whole lot of that applies to us. What we do know is that the onset's 5 to 15 minutes, and we know that albuterol works pretty quick. It works better the more that it's inhaled. So definitely having somebody put on a non-rebreather mask, or if we're giving it through a standard, T-pipe style nebulizer, instruct the patient to breathe that medication in deeply, take nice, big, slow, deep breaths, and get that down into their bronchioles as far as they can, because you see that it is inhaled. When inhaled, it's distributed to those muscle cells, so we need to distribute that throughout their lungs. We want them to take good, nice, deep breaths and get that deep down into their lungs where it can work. Side effects: tremors, anxiety, dizziness, headache, cough, reflex bronchial spasm, palpitations, tachycardia, and hypertension. I personally have never seen a EMS-caused side effect of albuterol. I did see years ago, 7 or 8 years ago, I had a patient that had a prescription to albuterol, and she had really bad asthma, and she took an entire month's worth of albuterol breathing treatments back to back to back. So she basically chained about 50 treatments. There was a big box that she had got that was a month's worth, and she ran out of breathing treatments. And then once she had ran out, and I believe the number was 50, when she had ran out of breathing treatments that were in that box, she then called 911 because she could not breathe anymore. So she puffed her entire inhaler and then started on her breathing treatments and ran through the whole box. So we're talking hours and hours of breathing treatments. And when we got there, she was still having a really hard time breathing, and her heart rate was extremely high. I don't remember what it was, but I remember it was close to 200. She essentially had basically put herself into SVT. She was extremely tachycardic. I don't remember exactly what the rate was, and she still couldn't breathe. So we ended up having to use MAG to fix her asthma. But I have seen tachycardia, palpitations, and hypertension, tremors, anxiety, dizziness, headache, that stuff all caused by that one call. But outside of that, I've never seen a side effect caused by albuterol. It's very safe. We may have out there before. I'm not saying that you won't, but I personally have never seen them in the last 10 years. So what do we got left here? The main thing here is the dosage and how this comes. So I'm house applied first. We know that albuterol comes in 2.5, and it comes in the little vials. And we pop the top and we push that into the vial. So each of those are 2.5. Our dosage generally is 5 for adults, so it's going to be 2. And then our max dosage for kids is 2.5, so it's going to be 1. That's generally our dosage for what our dosages are, and it may be repeated. So you can give 5, and then you can repeat that once. And as a kid, you can give 2.5 and then repeat that. So super easy. Albuterol is very, very hard to mess up. And you'll see this here on the uncertain etiology. We just give albuterol. This is how I remember this when I first started, how it made it easy for me to remember how to give this right. But if it's uncertain and I don't know what it is, and I ask the patient, do you have any breathing problems, any respiratory history, past medical history, or it's just smoke inhalation, it's an acute thing that happened, and they say no, then it's uncertain etiology or smoke inhalation. I give just albuterol. So then you go down there to the next is asthma, COPD. So the thing that changes with asthma and COPD is that we're going to add atrovent. So you see the 5 milligram nebulized with ipratropium bromide, which is atrovent, and we can repeat that twice. Okay, so if we are doing asthma, COPD, allergic reaction, bee sting wash, we add the atrovent. Okay, so if it's uncertain, it's just albuterol. So it's kind of our catch-all. It's extremely safe, and it's used all over the world all the time, every day by millions of people. Very little bad effects to it, so it's extremely safe to do. We can almost always use albuterol. If they have COPD or asthma, we're going to throw the atrovent in as well. And what else on protocols? Last is COVID. Okay, so something I've seen going on, and we didn't do as good a job as we probably should at updating our protocols during COVID. We just kind of we didn't update the protocols themselves. We just kind of put out guidance for people. But the thing to remember with COVID is never give an aerosol breathing treatment, some type of nebulized treatment, whether it be albuterol or atrovent, to somebody with COVID in an enclosed space, because you are spreading that all over the place, and you yourself are going to end up getting COVID. So be careful with that. And so if you're going to give a breathing treatment with COVID, do it in the patient's house that's already contaminated. Put them on the breathing treatment there, let the breathing treatment complete, and then take them to the hospital. That will help them a lot, and it will keep you away from them. Put that treatment on and then back up, let that treatment complete, so you're not getting yourself, your ambulance, and everybody in the truck get COVID all over the truck. So next is in the hospital. Do not take a patient into the hospital wearing a breathing treatment. They will freak out because you're nebulizing COVID into the air. So just remember with COVID, breathing treatments, do them on scene and do them in a ventilated area. Do not do them in the back of the truck on the way to the hospital, and do them on the way into the hospital. You will be quickly asked to turn those off. So that's about it for albuterol. And we see all the protocols we can use there. Super easy to use. As you know, we deliver Albuterol through a nebulizer. You guys are going to do some skills after this on the different ways to deliver O2. So we can give Albuterol breathing treatments through the regular nebulizer, the peace pipe style. We can do that. We can do it through a non-rebreather. We can also, the non-rebreather with the nebulizer attached. We can also do it inline on a ventilator. So you're working on all three of those skills. Make sure you know how to put an old nebulizer together. Make sure you know how to put the non-rebreather style nebulizer together. Make sure you know how to troubleshoot it. Inside that nebulizer in the bottom is a little blue disc or a green disc, depending on what brand it is. Take that disc out and then try to nebulize and see how that works, so that you know if that does happen to you. It's happened to me several times. Sometimes they're not in there, or they get flipped over, or they fall out when you're putting them together and the nebulizer won't work. So you know how to troubleshoot that if it doesn't work. And then make sure you know how to use the T adapter that is in your ambulance to do an inline breathing treatment. And if you don't have that T adapter, and you do not know how to do the inline treatment without, get with me and I'll walk you through it. If you have any questions about this protocol or any of this, let me know and I will get them answered for you. Thank you guys for watching once again, and I'll see you guys soon on our next training.